in brief at the end of the last session. Oral anticoagulants can be warfarin or DOACs. Warfarin is orally administered vitamin K antagonist available in the market for more than 60 years and has a wide list of indications. It's uniquely approved now for anticoagulation in patients with valvular heart disease. DOACs is a group of a new oral directly acting anticoagulants. These drugs offer an improvement over VKAs by the virtue of predictable dose responses and so do not need routine monitoring, no food interactions, and limited drug interactions. DOACs lie either factor X inhibitors or thrombin inhibitors. The factor X inhibitors are apixaban, edoxaban, rivaroxaban, and batrixaban, while the direct thrombin inhibitor is dabigatran. As regards their indications, they are approved for venous thromboembolism prophylaxis, treatment, non-valvular AF treatment, and risk reduction of major thrombotic events in combination with aspirin. The full list of indications are approved for rivaroxaban at multiple doses. The first three indications are approved for apixaban, while edoxaban and dabigatran are not approved for VTE prophylaxis. And as regards batrixaban, it's approved for prevention of venous thromboembolism in patients hospitalized for acute medical illness at risk for thrombosis. And unfortunately, it was withdrawn from the market for business issues. The advent of DOACs has revolutionized the anticoagulation management in both stroke prevention and VTE treatment and prevention. Clinical trials and real-world data have shown that DOACs have similar efficacy and in some cases improved bleeding safety profiles compared with the vitamin K antagonists. The increasing use of DOACs, led by their convenience of use and generally lower bleeding rates, calls for re-evaluation of the current VTE treatment models, as the benefits of long-term anticoagulation may begin to outweigh risks and inconvenience associated with their predecessors. We are in situation to switch from anticoagulant to another. We can switch from warfarin to DOAC, from DOAC to warfarin, and from a DOAC to another DOAC. Switching is appropriate for patients from warfarin to a DOAC may be considered in cases of drug intolerance, therapeutic failure, and patient preference. This cannot be considered in patients with prosthetic mechanical valve, with moderate to severe mitral stenosis, who are breastfeeding, requiring a higher INR than the standard range of 2 to 3, patients with severe renal impairment, less than 15 milli per minute creatinine clearance, and as regards dabigatran, if the creatinine clearance is less than 30, and prescribed DOAC interacting drugs. Traditionally, this list usually included patients on triple therapy, warfarin plus dual antiplatelets, patients with antiphospholipid syndrome, and patients with active malignancy. But recent research in the last 5 years have proven that DOAC use in these categories can be considered. As regards interactions, for the adult drugs and the ritonavir, dabigatran is contraindicated. Rivaroxaban and apixaban are not recommended, and edoxaban can be used with dose reduction. For rifampicin and the anticonvulsive drugs, dabigatran also is contraindicated, and the other drugs can be used with caution. The pragmatic approach to stopping warfarin and starting DOAC in relation to the INR is to stop warfarin and start DOAC when INR is equal to or less 2.5. But the drug certificates recommend different INRs at which to initiate DUACs after stopping warfarin. For apixaban and dabigatran when INR less than 2, for edoxaban when INR less than 2.5, and for rivaroxaban it starts when INR less than 3. For apixaban, the dose is 5 milligrams twice daily when switched to from warfarin, and can be reduced to half the dose if the age is above 80, weight below 60, and the creatinine clearance from 15 to 29. For edoxaban, it's 60 milligrams once daily, reduced to 30 milligrams if weight less than 61, creatinine clearance from 15 to 50, and co-administration of antibiotics and antifungal drugs. For rivaroxaban, 20 milligrams once daily, reduced to 15 if creatinine clearance between 15 and 50 and presence of bleeding risk. For dabigatran, it's 150 milligrams twice daily, reduced to 110 milligrams twice daily if the age above 70 or creatinine clearance between 30 and 50 and bleeding risk. When we are in a condition to switch from DOAC to warfarin, it can occur in case of drug intolerance, therapeutic failure, patient preference, and new comorbidity or contraindication. It's important to consider that DOAC's half-life is affected by renal function, and the delay in onset of warfarin needs protection in the first few days after instruction of warfarin therapy. Two options are available. First, to individualize the action, for patients on apixaban, we commence warfarin in combination with apixaban. Apixaban should be continued for 2 days, after which point INR should be measured prior to each dose of apixaban. Apixaban should be discontinued when INR is 2 or more. For edoxaban at a dose of 60 milligrams, it will be reduced to 3 milligrams, begin warfarin concomitantly, and stop when goal INR is reached. If the starting dose was 30 milligrams, it will be reduced to 15, begin warfarin concomitantly, and stop when goal INR is reached. For rivaroxaban, we commence warfarin in combination with rivaroxaban. It should be discontinued when INR is in the therapeutic range. INR is measured prior to each dose of rivaroxaban being administered. For dabigatran, the conversion protocol depends on renal function. If the creatinine clearance is equals 50 or more, commence warfarin 3 days prior to discontinuing dabigatran. For creatinine clearance between 30 and 50, we commence warfarin 2 days prior to discontinuing dabigatran. Dabigatran can increase INR. INR measurements should be interpreted cautiously until dabigatran has been stopped for 2 days. Or the other option is to begin parenteral anticoagulation, what we call bridging, and warfarin at the same time. The next dose of DOAC is due, and when INR is at goal, we discontinue the parenteral anticoagulant. Simply switching from DOAC to DOAC, we begin the new one when the next dose of the previously used DOAC is due. Thank you.